In this unit, we'll talk about inserting the Combitube airway. The insertion is designed to be a blind. You don't have to visualize the cords or the glottic opening. Again, it makes it nice during CPR, so you don't have to stop compressions. The head alignment should be neutral to a slightly flexed position. Doing this will help ensure that the airway gets inserted into the esophagus. The operator, though, must have the ability to identify the proper placement in order to select which tube to ventilate through. Failure to follow standard procedures with a Combitube SA could cause the practitioner to ventilate through the wrong tube, thereby delivering air to the stomach and not the lungs. In Kalamazoo County, we will utilize the Combitube SA, which is designed specifically for patients that are 4 to 6 feet in height. Patients outside that range might need a different airway adjunct, such as the i-gel or an endotracheal tube. Inspection of the airway and prep for insertion requires the following steps. You need to test each of the cuffs by inflating the maximum inflation volume. For the upper cuff, that's 85 cc's. For the lower cuff, that's 12 cc's. We want to deflate those cuffs completely before insertion and leave the syringes attached to the connector. Lubrication of the Combitube should occur with a water-soluble lubricant with a small amount placed near the tip of the airway. Over-lubrication of the tube could cause problems as the lube will be in the obturator portion of the airway. With any advanced airway, we want to make sure and pre-oxygenate the patient. This again should include checking the lung sounds while using the BVM and OPA combination. This will help establish a baseline for ventilation prior to insertion of the advanced airway. We want to determine if the patient may have a difficult airway issue. If there's jaw problems, dentition problems, other traumas, or if the patient is outside of the range for the Combitube SA airway. And at this point, we should ensure that we have continuous monitoring of pulse ox. Insertion of the Combitube airway is done with the patient's head in a neutral or slightly flexed position if no spinal injury is suspected. Again, this will help ensure that the tube is placed into the esophagus. With one hand, lift the mandible and jaw forward, as seen in the diagram. Alternatively, you may use a curved laryngoscope blade, which we'll see momentarily in a video. Insert the Combitube following the same curvature as the pharynx. Gently advance the Combitube along midline, deepen the pharynx until the patient's teeth lie between the two circular rings marked on the outer end of the airway. If resistance is felt while advancing, assure that the mandible has been fully displaced forward. If resistance continues to be felt, withdraw the Combitube and reinsert. Once the Combitube is inserted, we need to inflate the balloons. So without holding onto the Combitube, inflate the blue port, number 1, which is the proximal pharyngeal balloon, with 50 to 75 cc's of air using the large syringe. The Combitube may displace outwards slightly. Once you've inserted the air, disconnect the syringe so the air doesn't leak. Once that's completed, then inflate the white port, number 2, which is the distal esophageal balloon, with 12 cc's of air using the smaller syringe. Again, disconnect the syringe prior to continuing. Now comes the portion where we decide where the tube has been placed and what tube we should ventilate the patient through. Again, this is a stepwise process that, if done incorrectly, could cause us to ventilate the stomach and not the lungs. So first we want to attach our bag valve mask ventilator to the blue tube and begin ventilations while assessing for placement. We need to watch for the chest to rise, listen for the absence of gastric sounds, and listen bilaterally for breath sounds. We should be measuring end-tidal CO2 as early as possible in this process. If the chest rises and there's no gastric sounds and we have bilateral breath sounds and CO2 is detected, we should continue to ventilate through the blue tube, tube number 1. The Combitube has been placed into the esophagus. If the chest does not rise and gastric sounds are present, then ventilating through the blue tube, you need to immediately switch to the clear number 2 tube. Once you do that, if the chest then rises and no gastric sounds are present, and we have bilateral breath sounds and CO2 detected in tube number 2, then we need to continue ventilations through the clear tube because the tube has been placed in the trachea. Whichever tube works best, tube number 1 because we're placed in the esophagus, or tube number 2 because we're placed in the trachea, it's a wise decision to somehow mark those 2 tubes, either putting tape around the tube that we're going to use, or there's an elbow that comes with the Combitube airway that we can place over the tube that we're not using, because that will not allow the BVM to be hooked to that particular tube. Once the Combitube has been placed, all our confirmations are complete, the airway should be secured. The Thomas tube holder will accommodate the Combitube for this application. This is a quick video of that Combitube insertion. In this particular case, the practitioner uses a curved laryngoscope blade to help move the tongue and jaw up out of the way.
It's okay.
So you can see the practitioner use the curved blade to move the mandible out of the way, use a straight midline insertion following the curvature of the anatomy, inflated the large cuff, cuff number 1, then the smaller cuff, and began to ventilate on the blue tube, or tube number 1. They had chest rise at the end, so we believe we're in the correct tube. Further confirmation, the lack of epigastric sounds and positive breath sounds bilaterally, along with capnography, will confirm the airway is in fact ventilating our patient. Suctioning for the Combitube is very simple. If ventilated successfully through blue tube, the number 1 tube, and any gastric distension is present, you may insert a suction catheter through the clear number 2 tube. Attach the suction and decompress the stomach.